Da paso ahora a la siguiente sesión, donde discutiremos brevemente sobre las guías de práctica clínica. Aquí traigo a nuestra memoria a uno de los escritores de la antigüedad, del principio de la Edad Media, Alejandro de Tralles, donde reporta cómo va a presentar a uno de sus amigos lo que ha armado desde su rica experiencia en tratamiento de varias enfermedades. Dice: aunque ahora soy un anciano y ya algo limitado para ejercer, obedecí y escribí este libro después de haber colectado mis experiencias a partir de mis muchos contactos con enfermedades humanas. Y yo sé que esto complacerá a mucha gente, que no mostrará envidia al mirar el buen razonamiento de mis teorías médicas junto con la brevedad y claridad de la exposición. Podemos ver a alguien en quien la autoestima no estaba ausente y en quien, sin embargo, nos dejó muchas obras de descripción de padecimientos importantes. Aquí es la foto de una de las ediciones del año 1500 aproximadamente, muy temprano en la historia de la medicina. Tenemos que recordar a alguien cuyos escritos sirvieron como guía de práctica para muchas generaciones de médicos. ¿Cómo definimos ahora las guías de práctica clínica? De acuerdo al reporte del Institute of Medicine de 1999, las guías de práctica clínica son recomendaciones desarrolladas de forma sistematizada para asistir a los clínicos y al paciente acerca de las decisiones más adecuadas en circunstancias específicas. ¿Es esto necesario para el clínico? Bueno, en el caso del tratamiento de osteoporosis, ¿por qué una guía de práctica clínica? Presento a ustedes aquí una gráfica de artículos por año en PubMed sobre el tratamiento de osteoporosis. Aquí pueden ver cómo ha ido creciendo desde 1932 hasta el momento actual, un promedio en los últimos años de 2.800 artículos anuales solo de tratamiento por osteoporosis. Evidentemente no es difícil, es imposible mantenerse exactamente conectado con todos estos avances en el tratamiento de osteoporosis. Nada menos en este año van más de 2.500 artículos sobre este tema. Además de numerosos artículos sobre otros aspectos de diagnóstico, de criterios de clasificación, de práctica clínica, etc. Además, en el campo de la osteoporosis han surgido algunos avances en nuevos conceptos de diagnóstico y clasificación del riesgo. Existen algunos medicamentos nuevos, probablemente no tantos como quisiéramos, pero hay algunos medicamentos nuevos. Y tenemos actualmente respuestas incompletas sobre duración del tratamiento en pacientes individuales, sobre la secuencia del tratamiento, sobre eventos adversos, etcétera, etcétera. Hay pues preguntas que todos podemos intentar utilizar como una guía cuando practicamos ante un paciente individual. Las guías de práctica clínica ahora se desarrollan siguiendo metodología muy precisa, muy compleja, y donde incluye las evidencias como el fundamento para todas las recomendaciones, aunque parten de médicos que se consideran expertos en el tema. Y para esto me da mucho gusto presentar a la doctora Pauline M. Camacho. Ella es endocrinóloga, profesora de medicina, directora del Centro de Osteoporosis y Metabolismo Óseo de la Universidad de Loyola y del Bone Disease Center en Illinois. Ella es miembro de la Asociación Americana de Endocrinólogos Clínicos y del Colegio Americano de Endocrinología, y es la copresidenta de las guías, de la fuerza de tarea de las guías de manejo de osteoporosis publicadas por estas asociaciones. Tengo que decirles que en las últimas publicaciones que he hecho y las últimas presentaciones he incluido el nombre de la doctora Camacho en incontables ocasiones, puesto que su nombre está ahora ligado a muchos conceptos que estamos manejando cotidianamente. Y sin más, los dejo con la doctora Camacho, que nos va a presentar las guías de estas asociaciones médicas de endocrinología, de diagnóstico y tratamiento de osteoporosis. Doctora Camacho. I will stop sharing my screen, and now you can start sharing yours, okay?
Okay, great. Okay, is that clear?
That's quite clear. Thank you.
Great. Thank you so much. Good morning, everyone. Greetings from Chicago. It's a warm day today here, but it's probably one of the last few warm days in the city. I hope all is well with you, and I want to thank the organizers for this very kind invitation. I'm really excited to talk about the most recent guidelines of ACE and the American College of Endocrinology, which was published in Endocrine Practice in May of 2020. This is the task force that has brought this forward. In 2020, I can say that this is a product of a lot of hours of hard work over many, many years. And it was our goal to present the latest and the greatest in the treatment of osteoporosis. It is an update to the 2016 guidelines. I think we tackled a lot of good things here. For my conflict of interest, my institution, Loyola University Medical Center, was one of the sites for the ART trial for Amgen. The key updates in the 2020 guidelines of ACE include diagnostic criteria for osteoporosis. We also elucidated and clarified the risk stratification criteria that helps guide not only the initial choice of agents, but also the duration of treatment for postmenopausal osteoporosis. We included Aromasozumab in the treatment algorithm, and we also provided new guidance on transitioning or discontinuing agents that are used for osteoporosis therapy, including denosumab. We know that osteoporosis is very common. We all see this day in, day out. 54% of adults over the age of 50 in the US have osteoporosis. And that's about 10 million individuals. And though if we include those with low bone mass, that's 43 million. It is estimated that by 2030, there will be more than 13 million patients with osteoporosis. The likelihood of a hospitalization over 8 years increases by 200% in a patient who suffers from an osteoporotic fracture. The likelihood of death increases by 83%, and there's a 30% mortality within a year. Now, looking at just new osteoporotic fractures, which may include spine or, let's say, wrist fracture. Among Medicare beneficiaries, within 12 months of that fracture, nearly 1 in 5 will die. The total cost of care for Medicare is very expensive, currently $57 billion from 2018, and this will increase to more than $95 billion in 2040. Okay, it keeps going back. The treatment gaps in osteoporosis are huge. In 2020, 40% of patients who suffer from a hip fracture received treatment. In 2011, only 21% of patients received treatment. That's not good. We're heading in the wrong direction here. The estimated probability of medication use after a hospital discharge was 29%. And there are many reasons. There's a lot of confusion or concerns about treatment for osteoporosis, not only among patients, but also among clinicians. The rare adverse events, jaw necrosis, atypical fractures, these have been weighed heavily in the minds of patients because of all the media publicity, and it is a major reason that people do not want to be treated for osteoporosis. So ACE recommends that all postmenopausal women over the age of 50 should receive osteoporosis screening. Now, you can use tools like FRAX, you can use a bone density test, but do something. Assess them for their fracture risk. All women over the age of 55 should have a DEXA scan. Medicare covers that right now. But younger women without who are less than 65, but if they have a history of a fracture that is coming from minimal or low trauma, or they have other high-risk features, including maybe receiving treatment that causes osteoporosis, they should receive a DEXA scan even earlier than 65. The WHO criteria for osteoporosis is as follows. We're all very familiar with this. This defines the thresholds using bone densitometry. So T-score of negative 2.5 or below defines osteoporosis. If there is a fragility fracture in an individual with a T-score of negative 2.5 or below, that would be severe osteoporosis. Now, the ACE diagnostic criteria expands upon the NINOF criteria, or rather, that previous criteria I talked about. So we do agree that negative 2.5 or below in these sites, lumbar spine, femoral neck, or total proximal femur, or as an alternate site, the 1/3 radius that defines osteoporosis. If there is a history of low trauma, spine or hip fracture, regardless of the bone mineral density, and in the absence of other metabolic bone conditions, that defines osteoporosis. You don't need a DEXA scan. If the patient is in this osteopenia range, which is negative 2.5, between negative 2.5 and negative 1.0, but they have a history of a fractured humerus pelvis distal forearm, that is osteoporosis. And then lastly, number 4, if they're in the osteopenia range, but they have a high FRAX score, and you can even adjust that FRAX with your trabecular bone score. If the probability of fracture is exceeding treatment threshold for your country, then that defines osteoporosis. It is really, really important that the evaluation, the treatment of osteoporosis starts with an evaluation for secondary causes. These are quite common. If you start doing a comprehensive test for these conditions, you'll find that it's out there. Up to 1/3 of women with osteoporosis, even if they're asymptomatic, they don't look like they have certain conditions, there's going to be issues. The most common ones, of course, that we find are disorders of calcium metabolism, such as hyperparathyroidism or hypercalciuria, malabsorption for calcium. Individuals with celiac disease can sometimes be detected in bone clinics, not in the GI clinic. Vitamin D deficiency, of course, is very common, hyperthyroidism, and rarely we do pick up patients with Cushing's disease or Cushing's syndrome. This is the evaluation that ACE recommends, and it's quite comprehensive. I do most of these, definitely. CBC, a CAM panel, 24-hour urine calcium, very, very important. You're looking for a high level and a low level, both of which can cause issues to the bone. Parathyroid hormone, TSH, screening for celiac disease, serum protein electrophoresis, looking for multiple myeloma, certain conditions. Sometimes if I detect or if I suspect Cushing's, I might order screening for that, whether it be dexapression or urinary cortisol or salivary cortisol, whatever your choice of screening is. Serum tryptase looks for mastocytosis, which is very rare, but could be out there too. And very rarely we sometimes need bone biopsies, but that is definitely extremely rare. The non-pharmacologic management for osteoporosis is very important. It should not be underestimated. Patients should be getting adequate calcium and vitamin D if they are going to be receiving treatment for osteoporosis. For women 51 and older, the recommended total intake of calcium is 1,200 milligrams per day. Vitamin D, you can start them on 1,000 or 2,000 IU per day to maintain optimal levels between 30 to 50 nanogram per ml. Now, sometimes patients might need a whole lot more than 2,000 IU if they have a history of malabsorption or gastric bypass, or if they're obese. Weight-bearing exercises are really good to recommend to patients. I also recommend balance exercises. We know that as we get older, our balance is no longer as good as when we were 20s, and it just goes. So if you are going to try to prevent falls, it's good to advise them also on measures such as exercises to improve balance. Smoking cessation, that's a given. Limiting caffeine and alcohol consumption is also good to recommend. Now we talk about the pharmacologic agents for osteoporosis. They can be divided into the anti-resorptive agents, which include bisphosphonates, selective estrogen receptor modulators, or SERMs, estrogen, calcitonin, and denosumab. This is the largest group and probably the most commonly used all around the world. Then we have the parathyroid hormone analogs. There's teriparatide, brand name is Forteo, and abaloparatide, brand name is Tymlos. These are anabolic agents. And then lastly, the newest agent that we have is Aromasozumab, which is a humanized monoclonal antibody against osteocyte-derived sclerostin. We will talk about that in a little bit. So it really is important to know who needs to be treated, right? That's where it starts. First, you make your diagnosis, and then you decide who needs to be treated. These are our recommendations. If your patient has a history of a fracture in the spine, femoral neck, total hip, if your patient has a T-score between -1 and -2.5 in the spine, femoral neck, total hip, or the distal third of their radius, and if they have a history of a fragility fracture in the spine or hip, they should be treated. So even though their DEXA looks like they're in the osteopenia range, but they have this history, they should be treated. If they have the classic definition by bone densitometry of a T-score of -2.5, then treatment should be recommended. Number 3, if their FRAX probability is more than 20% for major osteoporotic fractures and more than 3% for hip fractures, even if their T-score is in the osteopenia range here, then treatment should be recommended. Risk stratification. In 2016, we provided risk stratification. However, we thought it needed more clarification, and that's what we did for 2020. So who do we define as that individual who is very high risk for fractures? If there is a recent fracture in the last 12 months, patient is fracturing while on approved therapy, if they have multiple fractures, multiple compression fractures of the spine, for example, fractures while they're on drugs causing skeletal harm, example, glucocorticoids, or a T-score that is very low, less than -3.0. And clinically, if they are high risk for falls, and by FRAX, if their fracture probability is very high. So just to illustrate what we mean, not everyone is the same. Someone walks in, she's only 65, she's not really had fractures, this is her fracture risk. So she would be high risk. We know she's high risk. Her bone density defines her to have osteoporosis. But this person right here is different. she is the very high fracture risk individual we're talking about. Even someone like this is already very high fracture risk. And then a little bit older, that just depends on, where you put her in the spectrum. So take note of this categorization because we're going to be referring to this in the algorithm. So this is the algorithm. By the way, the ACE guidelines and this algorithm is available for download through the ACE website. Also, you can download it from Endocrine Practice. So the main thing here, after your diagnosis is made and the evaluation for causes of secondary osteoporosis is done, and you've corrected calcium and vitamin D deficiency, you want to risk stratify them. Is it that person who is high risk with no prior fractures? Or are we dealing with someone with very, very high fracture risk, the lady in the wheelchair? The initial agents are driven by this categorization, as you can see, and even the duration of treatment will also be determined. So I'll go into this in further detail. So here, we are looking at a high-risk individual, but no prior fracture. It is perfectly fine to start them on oral agents, alendronate, risedronate, but there may be situations when you want to go with an injectable for whatever reason. Denosumab would be up there, zoledronate would be up there. We did put ibandronate and raloxifene as alternate therapy because of the lack of fracture risk reduction data. These patients are then evaluated or reassessed every year, not only for their treatment response, but their clinical state and their fracture risk. Now we're talking here about the very high risk individual who already has had prior fractures, maybe has already received other treatments. The initial agents would be the injectables. And note that these are really listed in alphabetical order, not necessarily in order of strength or potency. So we have options like abaloparatide, denosumab, Aromasozumab, teriparatide, and zoledronate. If, access to these or cost is not doable, then it is also possible to just go with oral agents. Just like the other group, they really should be reassessed yearly for response to treatment and their fracture risk. Now, we know that treatment with bisphosphonates is not forever. We want to mitigate the rising or increasing risk of these very rare adverse events. So patients can go on drug holidays, and I'll talk about when to initiate drug holidays or bisphosphonate holidays. But first and foremost, before you consider a bisphosphonate holiday, your patient should no longer be high risk for fractures. They should have stable or increasing BMD on serial DEXAs. They should really not be fracturing, and there should not be other comorbid conditions that increase their fracture risk. And no new medications that can cause bone loss should have been started in the couple of years prior to the bisphosphonate holiday. How long should patients be treated? So for the high-risk group, it would be 5 years for oral bisphosphonates. And if you chose zoledronate, that would be 3 consecutive years. For the very high-risk patient, you can treat them for up to 10 years with oral bisphosphonates. And if you chose zoledronate, up to 6 years in a row. After the discontinuation of treatment, then you want your patients yearly. You get their DEXA scans. You can get bone turnover markers if you wish. But if your patient develops a new fragility fracture immediately, it doesn't even matter how long they've been off treatment, they should be resumed. Treatment should be resumed. If there is a significant decline in bone density, and it's an accurate test and it's consistent, then treatment should be also resumed. For those of us also follow bone turnover markers, they really are quite helpful. Because you can see them rising even within a year of discontinuation, and you can see what's going on in a more dynamic, way. And it even gives you advance notice of what's going to happen in their DEXA scan and what's happening to their fracture risk. So I was asked to present some cases that illustrate differences between this guideline and the 2016. And I want to show you this one case. It's quite common to see actually someone like this. 58-year-old Caucasian female was referred to the bone clinic due to screening, her screening DEXA, which showed osteoporosis. Her lumbar spine T-score initially was negative 2.8. Her femoral neck T-score was negative 1.8. There is no prior fractures. She has a history of kidney stones, physical exam, vital signs. Those were stable. So what do we know about this case? This patient should not really be having osteoporosis at this young age, right? Even though she is not fractured, that BMD is quite low. Her Z-score is lower than -1, meaning she's more than 1 standard deviations below other women of the same age. As we showed in the algorithm, work them up for secondary causes. I think this is very important. The younger they are when they present with osteoporosis, the more likely that they have something wrong with them. This patient already I had a clue because of her personal and family history of kidney stones. This is one of the most common secondary conditions that I detect. She actually did have idiopathic hypercalciuria, her 24-hour urine calcium was high, 360 milligrams in 24 hours, or 6 milligrams per kilogram. Over 4 milligrams per kilogram would be considered high. Parathyroid hormone was mildly elevated as the body's way of reacting to the calcium losses and the overall calcium deficiency. So for this patient, I would definitely ensure that she is calcium and vitamin D sufficient. I will put her on a thiazide diuretic so I can lower the calcium losses and also reduce her risk of another kidney stone. She is high risk, but she's not in the very high risk category. So I would start her on an oral bisphosphonate, either alendronate or risedronate, follow her with serial DEXAs, treat her for 5 years, and then initiate a drug holiday from the oral bisphosphonate. At some point, a couple of years later, you will see that her bone density will start to decline. The bone turnover markers will probably start rising. And when it becomes significant, then you can resume treatment. So that is the classic way that we deal with someone who is in the high risk group. And this illustrates the duration, what to do, drug holiday, and when to resume treatment. Let me switch gears a little bit and talk about the new drug for osteoporosis, which is Aromasozumab. Aromasozumab is a humanized monoclonal antibody that inhibits sclerostin. This is a protein that's secreted by osteocytes to reduce bone formation. So if you have an inhibitor of a protein that reduces bone formation, the ultimate endpoint is increased bone formation, correct? So this is an anabolic agent, but it also has an anti-resorptive effect. So it kind of is a dual action agent. It was approved in April of 2019. Not sure yet if it's approved. Maybe the organizers can let me know if it's already been approved in Mexico. Perhaps it is. It is indicated for osteoporosis in postmenopausal women at high risk for fractures, or those who have failed or are intolerant to other treatments. It's limited to 12 months of use, and it's given as a subcutaneous injection. So it actually comes in 2 injections, one on each side, totaling 210 milligrams monthly. There's a black box warning because there was a very small risk that was significant, but it was seen. So there's a black box warning for a potential risk of MI, stroke, and cardiovascular death, and should not be used in patients who had an MI or a stroke in the previous year. So there were two trials, pivotal trials for Aromasozumab. The first one was the FRAME trial. It's a large trial. 7,000 women with osteoporosis were given Aromasozumab or placebo for 1 year. And then that's followed by an open label. During this time, everyone got denosumab. So what did they find? 73% lower risk of new vertebral fracture at 12 months. So here, after 1 year, this group had 73% lower risk of new vertebral fractures. No significant difference in non-vertebral fracture at 12 months. And at 24 months, so here at the end of 24 months, everyone already got treated. 75% decrease in the risk of vertebral fractures after the transition to denosumab. The ARCH trial is smaller. This is the one that Loyola had participated in. It is also older group and more severely affected group because the fragility fracture was required for inclusion. There were two groups, so they were randomized into Aromasozumab and alendronate. No placebo here, no placebo. This went on for 12 months, and after 1 year, everyone then went on alendronate. So what was found in the ARCH trial? There was a 48% lower risk of new vertebral fractures in the denosumab group. Non-vertebral fractures was lowered by 19%. Hip fracture risk was reduced by 38%. And the adverse events was overall similar between the arms. And this is where the black box warning was coming from. Positively adjudicated serious cardiovascular events was 2.5% in the Romo group versus 1.9% in the alendronate group. There was one event of jaw necrosis in each arm, but it was during the open label phase. So what is the role of Aromasozumab in the treatment of osteoporosis? It is for patients with very high fracture risk. It is for patients previously treated with other anabolic agents, but it is felt by the treating physician that they still need more anabolic effect. So it gives you an added third year of anabolic effect. It's also for patients who are on injectable therapy because they're high risk or very high risk, but maybe they're not doing well for whatever reason. So just to illustrate this group, the very high fracture risk group, I have case 2. Case 2. So this is an 85-year-old Caucasian female who comes in a wheelchair brought by her daughter for second opinion. She's already lost 6 inches in height. She has had multiple vertebral compression fractures. She has been treated with alendronate for at least 5 years, but there was a new fracture found in the past couple of months. Her lumbar spine T-score was -4. Her femoral neck T-score was -3.5. She has a history of celiac disease. That's why she's so severely affected. But that's currently being treated with a gluten-free diet. So how would you approach this case? First and foremost, even without the bone density, when someone walks in like that, in that condition, they are high risk. They are in the very high risk group. She could have another fracture in the next couple of months. This patient already fractured while she was on oral bisphosphonate therapy. And she has a new fracture that hurts so much she can't sleep. So she will benefit from anabolic therapy. It will not only reduce her fracture risk significantly, but may also accelerate healing of her existing fracture. we definitely want to make sure that she receives calcium and vitamin D and that she's sufficient. At this point, I would probably switch her to an anabolic agent, teriparatide or abaloparatide, for 2 years. Now, after 2 years, Aromasozumab can be considered, or you can switch to an injectable anti-resorptive agent like denosumab or Reclast. One can argue also that you can start right off with Aromasozumab because that is also an anabolic agent. So we don't know which one is better for this situation. It's just going to be up to the clinicians. Serial DEXA's annual assessment of fall and fracture risk will be very important. So the other thing that we talked about in 2020, the guidelines, is transitioning from denosumab. We do know that denosumab cannot be discontinued just like that without a proper transition plan. There have been many case reports, case series showing multiple vertebral fractures upon stopping denosumab. Noted was a rapid decrease in BMD with discontinuation after 2 to 8 years. Bone turnover markers increased to values above baseline by 12 months after discontinuation. And those multiple vertebral fractures can occur without trauma. And they can be in multiple levels too. It's not just one. It's like I had one patient who had six vertebral fractures. My goodness, one is painful enough. That can occur 8 to 16 months after stopping the drug, sometimes as early as 3 months. So we want to protect against that. We don't want to make them better. And then when you stop the drug, they actually are worse off than when they started, right? So there should really be some way to protect against that. And so this study was a 2-year randomized open label crossover study that looked at 250 women with osteoporosis treated with denosumab. And then we have a group here that got treated with alendronate, and then they switched over. So the main thing here is we're focusing on what happens here, the denosumab to alendronate group. The bone density after having received alendronate for a year remains stable. And of course, this one, this is obvious, but this is not the main point here. The main point is we want to see what happens if you do denosumab followed by alendronate, and bone density remains stable. This is another study, smaller but important. It looked at women treated with denosumab for a mean of 2 years. They were then discontinued because they achieved osteopenia, and they were given 1 infusion of zoledronate. And then there's one group here that received denosumab. And then they were followed 12, 24 months. So looking at the group, the one that I highlighted there, that received denosumab, and then they got zoledronate for 1 year, the lumbar spine BMD was the same as baseline. Now let's go back to that again. Yes, so, and then there's one group that did not really get anything here during this period, and that decreased by 5%. Femoral neck bone density changes were similar in both arms. Bone turnover, this is expected. The group that did not receive zoledronate had significant increases in bone turnover markers at 15 months and remain elevated at 24 months. These changes were independent of BMD. There were 2 patients in the group that did not receive zoledronate who suffered from vertebral fractures, and there's one in the zoledronate group, but that was 1 year after the infusion. So this case 3 is actually a difference between 2016 and 2020, and you'll see. 65-year-old Caucasian female was found to have osteoporosis on a screening DEXA. She has no prior fractures. She has no other high-risk features. She's just a typical person who got Medicare and got a DEXA scan and was otherwise okay. She does report a history of severe GERD, and that's why she was not given an oral bisphosphonate. She was given denosumab by her primary care physician. Her baseline lumbar spine T-score was negative 2.8. Her femoral neck T-score was negative 2.5. Now, after 3 years on denosumab, her lumbar spine T-score had gone up to negative 2.2, and for her femoral neck T-score had gone up to negative 1.8. There were no fractures or any adverse events during that time. So based on the 2016 guidelines, we said treatment with denosumab can be indefinite. However, we now know that with the robust increase in BMD from the drug, patients are improving quite a bit. And some of them are going into the osteopenia range just within a couple of years of treatment, such as what happened to her. Now, if this patient has no other high-risk features, she hasn't fractured, she's not on steroids, then it's possible to consider transitioning her off, to letting her rest from being on medication. She's quite young after all, and I can't imagine she'll be on a continuous treatment for 30 years. Well, if you do want to transition her off or stop the drug, we highly recommend that there's a transition plan in place. We talked about using an infusion of zoledronic acid. Also, you can do alendronate for a year, but most of the time we do just use one infusion of zoledronic acid because it's very easy. And then during that year that they just received zoledronic acid, it's important to watch them closely. I personally follow bone turnover markers at 6 months, and I try to get a BMD and bone markers at 1 year. Most of the time, nothing happens. Sometimes I do see increases in bone markers that impress me, that are significant. But I have not had a patient who has had multiple vertebral fractures after transitioning to reclast or zoledronic acid. So then, after your patient has successfully transitioned, then they are essentially at that point on a drug holiday, right? You should follow them because at some point bone density will probably decline, as what happens also during bisphosphonate holidays. And perhaps once they are back in the osteoporosis range or they fracture, hopefully not, then you can resume treatment. So last thing I want to cover here are the many switchings that happen. And we kind of elucidated to this because we know that the drug you start out with may not go well or may not work out, and you may need to consider other treatments. But in the situation described here, someone who was started on an agent has progression of bone loss or recurrent fractures. So in essence, they're not doing well. First, assess compliance. Are they really taking the drug? Second, if you have not done so, reevaluate for causes of secondary osteoporosis and treat those. If the patient was on an oral agent, and you can see, for example, that their resorption markers are high for whatever reason, maybe they're not absorbing the oral, then you can consider switching to an injectable anti-resorptive agent. If the patient is already on an injectable anti-resorptive and remains high or develops even a higher risk for fractures, you can then switch them to anabolic agents, abalo, romo, teriparatide. And once again, always look for factors that lead to suboptimal response. So for the very high risk group, we talked about how injectables would be first line, and this just tackles what happens when you do. So you chose denosumab for your patient. You continue therapy until you deem the patient to no longer be high risk. And if you want to transition them off, ensure that you transition with another anti-resorptive agent. If Aromasozumab was chosen, first line, you would treat for 1 year and then follow that with sequential therapy with an oral or an injectable anti-resorptive agent. And that is the same if you chose abaloparatide or teriparatide. With these anabolic agents, they really lose efficacy quite fast if you do not do sequential therapy. So it's really important that something is put in place to maintain the benefits that you gain from the anabolic agents. Zoledronate, if that was the initial choice in the very high risk group, we talked about that you can continue for up to 6 consecutive years. If for some reason they're still not doing well, then you can consider switching them to an anabolic agent. So that wraps it up. In conclusion, everyone, please get a hold of the ACE Postmenopausal Osteoporosis Diagnosis and Treatment Guidelines. We talked about the initial treatment choice, duration of treatment based on the risk stratification. We tackled the addition of Aromasozumab to the treatment algorithm. And we provided further information on transitioning of osteoporosis treatments. And at this point, I am happy to take questions.
Thank you very much, Dr. Camacho. We already have a few questions. The first one is, maybe you have to know that before this session, we had a debate on which drug would I choose to start treatment of a postmenopausal woman. The session was about zoledronic acid versus denosumab. Mm-hmm. Which one would you choose as the first agent?
Okay, well, that's always a good question. I think it's a really nice debate, and things that help me actually in choosing between these two would be what is the T-score for the lumbar spine? What is the T-score for the hip? I think that in denosumab has a slightly higher increase in bone density for the lumbar spine, and definitely a higher increase in bone density for the hip. So if I want to impact both, and if hip is a problem, I kind of favor denosumab. I also look at practical things, because sometimes it's difficult with this, the fact that if you're on denosumab, you really have to stay on top of every 6 months. You cannot get lost to follow up and be lost and not get your third injection. That's dangerous. So reclass or zoledronate does have a logistics advantage. You just give them an infusion once a year for 3 years. If they can be delayed, nothing bad will happen. So there are different factors that I look at in choosing between these two. I also look at comorbid conditions like the rheumatologic patients when they're on other antibody therapy. I try not to use denosumab for those patients.
Why is that? I'm a rheumatologist, so...
Oh, you're a rheumatologist. My rheumatologists, they're kind of, I don't know if you guys have really ever looked at whether 2 antibody therapies can somehow attenuate the response to one, whether we impact your drugs or your drug impacts us. Okay. There's that concern.
Certainly, we need more research on that particular question.
Yeah.
There is another question which I would like to ask you. Have you used denosumab beyond 10 years?
Beyond 10 years, no, not really. It does work really well. And honestly, I have maybe someone who is beyond 5 years, but nowadays, at about 5 years or even earlier, I try to assess for even a rest period. I just don't want them to be over suppressed for too long for the risk of, I don't want them to face the same risks that we face with bisphosphonates. So not continuously, but I have cycled patients, let's say they do a couple of years, then we do a transition, come off, and then we do another cycle.
Another question is regarding the odontologic evaluation. Should you send your patient to a dentist? What kind of evaluation you would require before starting anti-resorptive therapy?
Right, that's very important. So most of my patients, their dentists already know, and the advice can be so detrimental, like never ever get reclass, never ever get Fosamax. Well, how is that, I think the main thing there to determine is there going to be an impending invasive procedure? Is there going to be an implant in the next year or two? But otherwise, I think everyone should be getting regular examinations by their dentist. But what happens at the exam? I think what needs to be determined is how bad are the teeth, and what is the chance that I'm going to need a tooth pulled. If you can, you get that over with before you start treatment. But sometimes those things can go over years, and you really cannot avoid. And I would not really hold off on treatment in someone who is very high risk just because they may get a dental implant next year, And I always reassure them too that there's plenty of case reports that if they get jaw necrosis, anabolic agents like teriparatide can be used to reverse the problem.
Okay. Regarding very high-risk patients, another of our attendees asked a question about, we only have teriparatide in Mexico now. And if you see a patient that evolves from high risk to very high risk, would you consider joining two agents? He asks specifically about teriparatide plus denosumab. Do you do that in real life?
In real life, very rarely done. I find that regimen to be very expensive. I can barely get one injectable agent approved, much less two. But we do have that in the guidelines when we know based on, I think, leader study that the combination can be better than one agent alone. But I think it's very important to know that denosumab is pretty powerful. If your patient is not doing well on denosumab, you got to ask why. Don't just automatically add on teriparatide. I think you should know, why is this patient not doing well? Maybe perhaps I've already over-treated the patient and kept them on denosumab too long, So I think that question needs to be seriously evaluated before doing